Thank you, sir. First of all, good evening to all. And I would like to thank Dr. Pawan Goyal and the IMA team for giving me a chance to speak here on this topic. Let me just share my slides. So, I would be speaking on rational use of antimicrobials and an essence of AMS. This would be the brief outline of my talk. First, so no talk is complete on AMS without understanding the AMR burden. So, first of all, I would discuss the burden of AMR, the epidemiology of AMR. Then I would discuss few clinical cases which we see routinely in our clinical practice, in our day-to-day practice, and understand how we can employ antimicrobial stewardship in that. I would also present ICMR data, and this data has been published yesterday only, so this is fresh off the press. And then finally, how to set up an AMSP program, and I'll also discuss some cases in AMSP program also. So, coming to the introduction of my talk, so AMR occurs when bacteria, viruses, and fungi and parasites no longer respond to the antimicrobial treatment, and they develop resistance over time. So AMR actually is a natural process that happens over time through genetic changes in the pathogen, but this actually has been hastened by we humans and animals by overuse of antibiotics, misuse of antibiotics, using antibiotics longer than the duration which is needed for the treatment of the infection. And we sort of have a central role in emergence of this accelerated development of antimicrobial resistance. The resistance which naturally happens over 50 to 100 years has been accelerated, and now that similar kind of resistance is developing in 10 to 15 years of time, and that is why we are needing newer antibiotics every 10-15 years. So AMR, we all know, poses an important global health challenge, and this AMR burden is significant in Indian scenario, and we would be contributing every third death globally due to AMR by the year 2050. Now, this is a very interesting meta-analysis which was published in Lancet few years back, and this is a very large meta-analysis which looked at all age-specific deaths and disability-adjusted life years attributable to AMR from 1990 to 2021, and they also projected a forecast that what would be the scenario in 2050. They were looking at 22 different bacteria, 84 pathogen drug combination, and 11 different infectious syndromes. And this is sort of a global study which was spanning across 204 countries and territories. And as I said earlier, the time frame which they had studied was from 1990 to 2021. So very interesting data from this study. If you look at the initial part of the study from 1990 to early 2000, you would see that the majority of the sepsis-related deaths were in children below the 5 years of age. But as the time progresses, and in the later part of the study, in the last decade, majority of the sepsis-related deaths were actually in adults. So there was a 60% decline in deaths related to sepsis in children. However, there was an 80% increase in deaths related to sepsis in adults. So, and we all know that our adult population, because of improvement in healthcare, and there is the length of the longevity of life has increased, and we are living longer. So we have more sepsis-related death in younger adults and older population compared to children. Now, this is another very interesting data which we need to look at. The above graph, the above world map actually looks at data from 1990, and if you look at, there were around 25 deaths per 100,000 population attributable to AMR in 1990. This improved slightly to around 15 deaths per 100,000 population, but the scenario looks way worse in 2050, where there would be around more than 30 deaths per 100,000 population, and this would be highest among all countries globally. Now look at other countries, even African countries, North American countries are actually faring much better than India. So that is the scenario which we are looking at. And this is another figure from the same study which looks at what are the different pathogens which would be leading to this increased death or increased AMR. And as expected, Acinetobacter, E. coli, Klebsiella, Pseudomonas, and Staphylococcus aureus, these would be the top 5 pathogens which would be responsible for almost 80% of the AMR related deaths by 2050, and this has been proven in the existing data also, which is from 1990 to 2021. Now, this is what I was talking. This is very, very interesting. I would just summarize the slide. Now, this slide tells you about the deaths attributable to the AMR. But if you go deeper into this, if you look at the South Asia, the figure of which depicts the deaths attributable to AMR from South Asia and globally, this tells us that every third death due to AMR would be contributed by South Asia. And if you add Southeast Asia, then every second death due to AMR would be contributed by South Asia and South Asia from the global AMR deaths. So the burden of AMR is very, very significant in Indian subcontinent, and India being the largest in that, with a very large population, we would be most significantly affected by this burden of AMR. So just to summarize the epidemiology, AMR burden is increasing in adults. Acinetobacter, Klebsiella, Staph aureus, E. coli are the most common pathogens in which AMR would continue to evolve over time. High AMR attributable death rates in India and South Asia, and every third death due to AMR globally would be contributed by South Asia. Now, what are the factors which are actually driving the AMR? Now, if you look, this is another study which was published in Lancet, and very interesting factors which arose from this study was that the two most important factors responsible for increase in AMR are actually your human antimicrobial misuse and animal antimicrobial misuse. Now, and these are the two most important factors. I know few of my friends who runs who have business is spanning across animal husbandry, hatchery. They have told me that they would use colistin and gentamicin injection, and they would inject it to the chicks to prevent them from getting infection. So that is the state of affairs we are dealing with. Then there is environmental contamination. We had a patient few years back who was working with Haryana government, was on duty and came to our hospital with near drowning. So after that, he became sick, was on ventilators. So the first culture on the day one itself, which we had taken from the endotracheal tube, isolated a carbapenem resistant Acinetobacter. So we have carbapenem resistant Acinetobacter, Pseudomonas, E. coli increasing in the community. That is very, very concerning. And these are patients who are otherwise healthy, have no healthcare contact, coming to hospital, and the first event itself coming to the hospital with a community-acquired carbapenem resistant pathogen, that is very, very concerning. Now, I will discuss few cases as I said earlier. So this is a 66-year-old male smoker from Rohtak, presented with fever, fever for 7 days, cough with expectoration for 7 days, pleuritic types of chest pain for 3 days. He was febrile. His saturation was 90% of room air. Had bronchial breath sounds in right memory area with fine crepitus. Other systemic examination was unremarkable. So he had a neutrophilic leukocytosis. TLC was 18,000, neutrophil 88%. CRP was elevated. It was 233. Blood cultures and sputum culture reports were sent, and they were awaited at this point. So X-ray showed there was a consolidation in right mid zone, and there was a cavity lesion also. And since this was a very short acute presentation, so this was a case of community acquired pneumonia. Gram stain confirmed the same, and the culture grew streptococcus pneumonia. Now, I have seen such kind of cases who are coming from the community receiving a very broad spectrum antibiotic like a carbapenem. So this is a patient who is fairly stable in OPD, has come from the community, no healthcare contact, has a community acquired pneumonia. So this patient would need just amoxiclav for the management, and he would need it only for 5 days. And I've seen patient today only. I saw a patient in the OPD who had a similar kind of a problem and had a community acquired pneumonia, was receiving cefixime for last 21 days, and now he has presented with an antibiotic associated diarrhea to me. So that is the state of affair we are dealing with. We are overusing antibiotics, giving more and more broader spectrum, and giving it for a longer duration than what is needed actually. So that is the problem. So coming to another case, this is a 22-year-old female with fever, sore throat, and rhinorrhea for 1 day. No known comorbidities, systemic examination unremarkable. And as Dr. Verma was talking earlier, took self-medication and took azithromycin 500 milligram once daily for 5 days. So basically, this patient actually had a viral illness, and that was probably influenza, and antibiotics actually were not warranted in this patient. So that is another abuse of antibiotics, and this is very common. A lot of patients would present with sore throat, and they would have taken azithromycin, doxycycline, or levofloxacin on their own without consultation with any physician or any healthcare provider. So another case, this is a 28-year-old male, HIV, presents with severe headache. CSF confirms that the patient has meningitis. Gram stain shows a diplococci, and the culture proves Streptococcus pneumonia, which is the most common cause of community-acquired meningitis. In the penicillin MIC and ceftriaxone MIC are in the fairly susceptible range. So this patient has an invasive pneumococcal disease due to Streptococcus pneumonia. Started on vancomycin plus ceftriaxone initially, and once we had the culture report, we just continued with ceftriaxone and dexamethasone and stopped vancomycin. So few learning points here is that once we started on an empirical treatment, which was a broad spectrum because this patient had a very severe syndrome. Once we had the culture report, we stopped the broad spectrum antibiotic and just continued with ceftriaxone here because vancomycin was not needed here, and we just continued this patient on ceftriaxone. So this is one very important learning point, that whenever you get a culture report, always try and de-escalate to a narrower spectrum or a monotherapy. We started with a broad spectrum and a combination therapy. In this case, and once the culture report was available, we switched to a narrow spectrum and a monotherapy for the treatment of meningitis. So this is what there has been a lot of change in meningitis guidelines, and now the penicillin MICs have gradually been reduced by CLSI because there is an increased penicillin resistance, and over time the resistance among Streptococcus pneumonia is increasing every year. We will discuss that in the coming slides. So this is a very nice ICMR report of AMR surveillance, and as I said earlier, that this report has been released yesterday only, and this is hot off the press. A very interesting data, which is actually very concerning. If you look at the meningeal isolates of Streptococcus pneumoniae, which is the most common cause of community-acquired meningitis, the penicillin sensitivity is only seen in 25% of the cases, and this was around 95% in 2005 and 90% in 2009. From 95% in 2005 to only 25% in 2025, we have come a long way, and this is actually really concerning. So that is the reason. But if you look at cefotaxime or ceftriaxone, the sensitivity is around 87%, which is still fairly good. So penicillin actually is no longer the drug of choice for community-acquired meningitis. You need to combine it with vancomycin, because that is the reason in our case also we started with vancomycin plus ceftriaxone initially, and once we had the culture report, we changed only to ceftriaxone. So empirical treatment for community-acquired meningitis, because the penicillin resistance has become so much, now the empirical treatment should be vancomycin plus ceftriaxone, and once we have the culture, we can de-escalate based on that. Now, coming to another case, this is another common scenario which we commonly face, especially those working in ICU. This is a 22-year-old male admitted to ICU for management of diabetic ketoacidosis, has got a central line. He receives IV fluid, KCl and insulin, and DK is reversed, and now is planned for discharge. Since infection is the most common cause for predisposition for somebody landing in DK, so that is the reason blood culture was sent for this patient. And one of the 4 blood culture is actually isolating a gram-positive pathogen, and the blood culture reports comes as a oxacillin-sensitive staph epidermidis. Now, blood culture has isolated a pathogen, and we know that infection is one of the leading cause for somebody landing in a DK. So what do we do now? So since we know that the staph epidermidis is a skin commensal, and the only 1 out of 4 blood culture bottles are isolating it. So this is likely to be a contaminant, which has happened because of improper sterilization technique while collecting the blood culture. And this does not need any treatment. So this is a common scenario we commonly see every day on rounds, on infection rounds, infectious disease rounds. And this actually does not need any treatment. We just remove the central line and discharge the patient. No treatment is needed in this patient. Coming to another case, this is a 58-year-old male, fever with chills for 3 days, severe headache, vomiting, altered behavior. Blood culture sent. Since this patient has a clinical diagnosis of meningitis, a lumbar puncture was done. and the blood culture grew Staphylococcus aureus, which was oxacillin sensitive. So this was a methicillin sensitive Staphylococcus aureus. This is again a healthy male coming from the community, no comorbidities, very short history, very sick, meningitis, and Staph aureus. Again, a common scenario because Staph aureus is way more common in community than we estimate it to be, and it is way less common in hospital setting where gram-negative pathogens like Enterobacteriaceae, like E. coli and Klebsiella are much more common. So this patient had a Staph aureus bloodstream infection and meningitis. So what would be the next best step? So this case actually why I'm discussing is that this is a case on which I have a lot of argument, lot of discussion with my colleagues, and they would make a choice that they would want to use a vancomycin. So vancomycin actually is not an appropriate choice in this case, and we should rather use cloxacillin or cefazolin in this patient, and that is actually what we did. So just to highlight my point, why I wanted to use cloxacillin or a cefazolin in this case, because we know that from data which is available to us, that whenever you are using vancomycin for a methicillin-sensitive Staph aureus, the outcomes are worse. You are using a broad-spectrum antibiotic which covers a pathogen very well, but still the outcomes are worse. So drug of choice for sensitive Staph aureus is actually your cefazolin or cloxacillin or fluclox or neficillin, not vancomycin, not teicoplanin, not linezolid. So that is a very important point which I wanted to highlight from this case. And as we can see from this meta-analysis that whenever you are using vancomycin for sensitive MSSA, and there are higher bacteriological failure, higher overall mortality, higher treatment failure, higher infection-related mortality, and higher 30-day in-hospital mortality. So all the subsets have shown a poor clinical response whenever you are using vancomycin or teicoplanin for management of a methicillin-sensitive Staph aureus. So just wanted to highlight this point that for a methicillin-sensitive Staph aureus, drug of choice is either cefazolin, flucloxacillin, neficillin, or oxacillin, and not vancomycin, daptomycin, teicoplanin, or linezolid. They are only reserved for methicillin-resistant Staph aureus, and 70% of our Staph aureus is actually methicillin-sensitive, and only 30-35% is actually methicillin-resistant. Now, coming to another case, which is very commonly seen by all of us. This is a 36-year-old female, came with complaints of generalized body ache and feverish feeling sensation for past 2 years. Now, a lot of middle-aged females would come with this kind of problem. No comorbidities, general physical examination unremarkable, and somebody decided to do a Widal test, and that turned out to be positive. And this lady was given tablets cefixime 400 milligram twice a day for 14 days. So this obviously was a wrong choice here, wrong decision here. The clinical syndrome was not compatible with typhoid fever. This lady had just had a feverish feeling for 2 years. Typhoid fever does not last for 2 years. So the syndrome here was not compatible. And one very important point which I want to highlight here is not just the antimicrobial stewardship aspect, but also the diagnostic stewardship aspect here. So here in what is diagnostic stewardship is that ordering a correct test in correct scenario. So Widal test is actually the most abused test, and it is actually not the recommended test for diagnosis of typhoid fever. Rather, blood culture is the gold standard test for diagnosis of typhoid fever that would not just would confirm the diagnosis, but also would tell us about the which would be the best drug, which would be the drugs which are susceptible and which are resistant and which we can use. So Widal test should no longer be used for diagnosing typhoid fever. Rather, we should be focusing on blood cultures. A Widal test has a very limited role, and that too only in the second week of illness and not in the first week of illness. So very limited role, and there is an increase and overuse of antibiotic by doing this test, especially in this kind of a patient which I just described. So this is what I was talking, the annual antimicrobial surveillance report, which was presented by ICMR and day before yesterday only. And this has got very interesting data. And the ICMR now is collecting data from around 70 odd centers across the country. And they started doing this since 2017. And now we have data available from 2017 to 2024 for various pathogens of interest like E. coli, Klebsiella, Salmonella, and various other fungi also. So ICMR with this regard is actually doing a very good work. Then they not just publish their AMR data every year, they also have come up with uh, uh, guidelines for prescribing antibiotics, and they are also available, and we all can refer to them whenever we have any doubts or whenever we need to prescribe any antibiotic for various syndromes. Now, Haryana also is trying to do something. Haryana government is also trying to do something, and they have made a AMR committee, and I was fortunate enough to be part of that committee. And we already have started working on developing an AMR and AMS policy for Haryana state, and the first meeting for that has already happened. And very soon you would hear more about this from the government as well as the DGHS also. Now, since we had discussed a case where cefixime was abused a lot due to a positive Widal test, let's discuss about the AMR in Salmonella. So look at fluoroquinolones. Fluoroquinolones, almost 100% resistance rates for against Salmonella, whereas the situation is still okay with regards to azithromycin, but the situation with regards to cephalosporin is actually started to worsen. Earlier, it used to be 100%. Now it has actually gradually declined to 97 and 98%. This may just seem like a 2% drop, but gradually this would increase. And I'm sure I'm very concerned about this because we have started to see ceftriaxone resistant salmonella, and there is an outbreak of meropenem resistant salmonella in southern states, and a lot of cases of even meropenem resistant, carbapenem resistant salmonella being reported from Bangalore and other parts of Karnataka. Now, this is what I was talking. At the moment, this looks quite okay, that ceftriaxone, cefotaxime, 98% sensitivity. But look at the pre-COVID era and the post-COVID era. If you look at it carefully into this figure, you would see that there is an increasing MIC. So that is how we develop resistance. First, there would be an increased MIC, and then you would start to see the emergence of resistance. And that has actually started to happen with Salmonella also. And very soon, in coming few years, we would see an increase in the incidence of not just ceftriaxone resistant salmonella, but we would also encounter meropenem resistant salmonella, and that would be very big challenge for a country like India, where we have a huge burden of salmonella in the community. Moving to the next case, this is a 54-year-old male who has a triple vessel disease, undergoes a CABG, as a short-term Foley's catheterization, is a diabetic, no urinary symptoms, no history of fever, no lower urinary tract symptom, and there was no insignificant pyuria in the urine. A urine culture was sent out as a part of the package, and urine culture actually grew an ESBL E. coli. And since the surgeons felt that since this patient is undergoing surgery, let's try and do something. And they at this point they call us. So what are the options we have? So we start amikacin, do some imaging, start meropenem, clear for surgery with usual prophylaxis, or repeat a urine culture. So actually, this patient does not have any lower urinary tract symptoms, no fever. So this patient has clinically no signs of UTI. So this patient does not need a urine routine or a urine culture, and this patient has an asymptomatic bacteriuria actually. So this patient does not need any kind of treatment. And as I said earlier, we should not only be practicing antimicrobial stewardship, but also should be practicing diagnostic stewardship also. And in this case, actually, urine routine and culture was not indicated because he had no symptoms. And this patient just had an asymptomatic bacteriuria. And asymptomatic bacteriuria does not need any treatment as per Infectious Disease Society of America guidelines. Needed to be treated only in two scenarios. One is a pregnant female, and second is some person who is undergoing a urogenital manipulation, which involves cutting of mucosa. So asymptomatic bacteria needs only treatment in these two scenarios, or maybe sometimes in first month after renal transfer. So coming to another case, this is a 58-year-old male who's a diabetes, hypertension, presents with chest pain, found to have TBD, undergoes CABG, usual surgical prophylaxis, continued for 10 days. Now has got a new onset diarrhea and crampy abdominal pain for last 2 days. So again, a common scenario, surgical prophylaxis, which should have been long back stopped. but continued for 10 days. And again, the argument with the surgeon, this is a common thing which happens, is that when they give a longer duration of prophylaxis, they are actually trying to reduce the incidence of surgical site infection. That is their argument when they are like prescribing the surgical antimicrobial prophylaxis for a longer duration. But this patient actually developed a C. difficile diarrhea. Now, my question is that why did he develop a C. difficile diarrhea? The answer to that is pretty simple, that because this patient was prescribed antibiotics which were needed only for 2 or 3 days, and those antibiotics were continued for longer duration than needed. That is the reason he developed a C. difficile diarrhea, and antibiotic exposure is the most common cause for C. difficile diarrhea. Then the next question, as I said earlier, from the surgical side is that they are trying to prolong the antimicrobial prophylaxis to reduce the incidence of surgical site infection. Because they would say that antibiotics are harmless, उनका कोई side effect नहीं होता, कोई problem नहीं होता, हम लंबा दे देते हैं, surgical site कम हो जाएगा, patient discharge हो जाएगा, 4-5-7 दिन hospital में मिल गया, 5-7 दिन घर पे भेज दिया, कुछ augmentin, cefuroxime, Ceftum वगैरह. That is the common scenario. But let's look at the data. Does the data support this or not? So this is again a very nice systematic review published in Lancet. Some 52 RCTs, more than 19,000 patients, very huge data. And they looked at SSI rates in 2 groups, in which only the surgical routine postoperative antibiotic prophylaxis was continued, and the other group was immediate discontinuation of the postoperative prophylaxis. So they found that the incidence was similar in the 2 groups. So there was no benefit of prolonging the antimicrobial prophylaxis. Now, another very large study in which they were trying to look at the duration and the type of surgical site infection and its benefit and its harms. So they again looking at the similar kind of a thing, whether the prolonged surgical antimicrobial prophylaxis, does it reduce rates of surgical site infection? So this is what are the harms if they are prolonging it. So very interesting data. They found that there was no difference in the surgical site infection rates in short versus longer duration in the cardiac surgery group and in the abdominal surgery group. But in the orthopedic surgery group, they found that there were higher rates of surgical site infection when they had given longer duration of surgical antimicrobial prophylaxis. So this is not, I'm not talking about reducing the rates of SSI. Here, by giving longer antibiotic prophylaxis, you are actually increasing the surgical site infection, especially in the orthopedic subgroup of patients. Then coming to the side effect, which was the another aspect which they were trying to study, they found that there were higher incidence of acute kidney injury in those who had received a longer duration of surgical antimicrobial prophylaxis, and higher incidence of Clostridium difficile, which probably happened in our case, which I had just described. So increased duration of antimicrobial prophylaxis does not reduce the risk of surgical site infection, and increased duration of antimicrobial prophylaxis increases the risk of acute kidney injury and Clostridium difficile infection. So moving to another case, again a common scenario, 55-year-old female undergoes a TKR, received prophylaxis with cefazolin, the usual standard surgical prophylaxis. No urinary symptoms, had some pyuria. In the pre-operative period, urine culture grew an ESBL E. coli, which was like a pan-sensitive. And since the surgeons felt that this urine culture is significant, and this patient was discharged on injection meropenem because they were concerned about that this E. coli may infect the implant, and then this patient was discharged on meropenem actually. Now this patient actually comes back to ER with new onset fever and shock, and the blood culture this time grew a carbapenem resistant E. coli. This patient was admitted in ICU, subsequently succumbs to septic shock and multi-organ dysfunction. Now, a lot of thoughts arising from this case was the treatment, first and the foremost one here, which I wanted to discuss, was the treatment for ESBL E. coli isolated in urine initial admission was really needed? The answer to that is no, and we have already discussed that this was a case of asymptomatic bacteriuria. This patient did not need any treatment for that. Second question was really meropenem needed? So again, even if we had decided to treat, we could have given something like nitrofurantoin or a Bactrim, because this was a pan-sensitive bug and meropenem here was really not needed. So this was a very broad spectrum and use of antibiotic for a syndrome for which it could have been avoided. Then the third question is, why did this patient develop CRE coli? This probably is because of exposure to meropenem, which is the most common reason. Whenever you are exposed to an antibiotic, the next infection which you would get is probably because of an infection which is resistant to the drugs to which you are recently exposed in the last 3 months. So in infectious disease, and this is an argument which I have with a lot of my colleagues, is that they would say, this is a common dialogue from their side, is that they are trying to cover for everything. They are trying to give a broader coverage, which actually is not the correct way to approach these kind of patients. So in infectious disease, we should, rather than trying to cover for everything, we should try and discover what actually is causing the problem, what is the cause of the infection, what are the bacteria which we are dealing, what are the susceptibility profile. And then based on that, we should prescribe antibiotic, not just give broad empirical coverage to each and every patient who comes for any sort of problem to us. So just to highlight the point which I had raised in the previous study, is that this study was looking at the outcomes when they had used a unnecessarily broad spectrum antibiotic versus not unnecessarily broad spectrum antibiotic. Means that they have given an antibiotic to a person which actually does not need it, was the one group, and the other group was they had given an antibiotic which actually needed it. So the outcomes are very interesting, and they found that the group which was received unnecessarily broad spectrum antibiotic, the mortality was 18%, and the group which did not receive unnecessarily broad spectrum antibiotic, the mortality was 10%, and odds ratio is almost reaching 2, and this difference was statistically very significant. So the point which I wanted to highlight is that if you give unnecessarily broad spectrum antibiotic to a patient who does not need it, the chances of that patient having some sort of side effect or increased mortality is actually twofold higher than a normal patient who does not receive unnecessarily broad spectrum antibiotic. Then another systematic review which was looking at onward development of resistance, which actually happened in our case, that does antibiotic exposure lead to development of resistance or further propagation of resistance. So this is again a meta-analysis of large number of studies, and they found that there was a significant positive relationship between antibiotic consumption and onward development of resistance. And they also noted that there was a more than twofold higher risk of developing infection due to an antibiotic resistant pathogen if you have been exposed to that particular kind of an antibiotic. And this is actually what happened in our case. A patient received unnecessary exposure to meropenem, and subsequently when that patient developed an infection a few days later, that infection was due to a carbapenem resistant pathogen. Coming to another case, again a common scenario, elderly male diabetic admitted in hospital for a jejunal perforation, undergoes resection and jejunostomy, has got a central line, needed a re-exploration, received an meropenem again on TPN, has got new onset fever, and blood cultures were sent, and the blood cultures this time grow Candida auris, which is a fungi. So this is a common scenario because this patient has a lot of risk factors for development of Candida auris, and the most important risk factor for development of Candida auris is somebody has got a CVC on TPN abdominal surgery and exposed to unnecessary antibiotics. So this is what I was talking, the risk factors for developing Candida infection. So here, had we been just stick to the usual surgical prophylaxis like cefuroxime in this case, or ceftriaxone plus metronidazole, this problem would not have arisen, because this problem has arisen because of unnecessary exposure to broad spectrum antibiotics. Now, this looks little complex, but because we are dealing with AMR, we need to understand a little bit of this. So this is in the famous Ambler classification we must have studied in our microbiology days. And if we have to understand AMR and practice AMS and manage our patient in a better way, we need to understand this actually. So one group is restricted spectrum beta lactams, almost 100% in the community. Then the second group is ESBL, around 80 to 90% in the community. Then third group is carbapenemase, around 30 to 60% depending on the pathogens in the community. So we need to keep at least this much in mind. Now this is what I was talking earlier, the epidemiology of ESBL. ESBL producers means the bacteria would be resistant to third generation cephalosporins, and this holds true for Enterobacteriaceae group of bacteria like E. coli and Klebsiella. So in E. coli and Klebsiella, the third generation cephalosporin resistance is somewhere between 73 to 88%. This is data from few studies, and I will discuss the ICMR data also a little later. Then carbapenemase. This is very, very concerning. And there are three different classes of carbapenimases like KPC, NDM, and OXA. Why I wanted to discuss this is because the Indian resistance mechanisms are very, very peculiar from the other countries. Globally, if you look at KPCs are the predominant resistance mechanism. And that is the reason most of the research for development of new antibiotics is actually targeted against KPC. However, KPCs are not our problem. Our problem is NDM and OXA. So our problems are very different from what the problems are encountered by the other countries in the world with regards to carbapenimases. And that is the reason we are not getting newer antibiotics which are India specific. So we need to focus, our pharmaceutical companies need to focus more on developing molecules which are targeting local antimicrobial resistance. Now, this is from the ICMR data. Just to give you a context, look at the cefotaxime or ceftazidime, which is cefotaxime third generation cephalosporin resistance. Overall, 15% sensitive only, overall in E. coli. Then carbapenems, overall 60% sensitive. So means almost 85% of your E. coli isolated from the 70-80 odd hospitals and around more than 12,000 isolates, almost 85% of them are third generation cephalosporin resistant. So that is the stage we have reached to. And in Klebsiella, this is actually even worse. So look at cefotaxime around again around 80%. The ESBL rates are pretty much similar between the two groups, E. coli and Klebsiella. But look at carbapenem resistance. Imipenem, meropenem, ertapenem resistance rates. 35% sensitive only, 31% sensitive, 36% sensitive. So that means every second isolate of Klebsiella out of the three isolate would be actually carbapenem resistance. So this is actually very, very scary. And similar thing is even worse. The scenario is actually even worse with regards to Acinetobacter. In Acinetobacter, look at meropenem, imipenem resistant, only 9% sensitive here. That means 90% of the Acinetobacter isolated from these 70 hospitals were actually carbapenem resistance. And mind you, these are not just corporate hospitals. These are predominantly public sector hospitals, government hospitals, civil hospitals, PGI, AIMS, these kind of hospitals, and very few corporate hospitals. So this is the state of affairs of drug resistance in the ICMR report. And this actually is very, very concerning. Now coming to things, how we can actually reduce this AMR and how we can address this issue is by practicing AMS. AMS is actually a very low hanging fruit, and we all can very easily practice in our clinical practice, and we can deploy this in our clinical practice, not just to improve the outcome of the patient, but also to reduce the burden of AMR. So what is actually antimicrobial stewardship? Stewardship is the careful and responsible management of something entrusted on one's care. So there are a few basic principles of antibiotic use, and there are 5 key aspects in this. Is the first one and the most important one is actually diagnosing and treating the infection effectively. So we need to identify the site of infection. We need to identify the type of infection. We need to send cultures before starting antibiotics, and we need to target empirical therapy to likely pathogens which are tailored to our local antibiogram. So every hospital should try and look at what are the different isolates in their hospital, try and look at their microbiological data, and try and come up with their local antibiogram. So and based on that local antibiogram, we can target our therapy, empirical therapy, and once we have the culture, we can give a definitive therapy to known pathogens, and after that, culture report is back. Now we have done the step one. We now we need to focus on second step, which is the AMS. So once we have seen that the patient has improved or the infection is cured, we should stop the antibiotic as early as possible, or we should stop the antibiotic when the cultures are negative and we believe that patient does not have an infection. In that scenario also, we can stop the infection. Like we commonly see that a patient has come with a chest pain, has got a low-grade fever, admitted into a heart command unit, found to have a acute coronary syndrome. So in acute coronary syndrome, antibiotics were started. And later on, we realized that the low-grade fever in this patient was due to an acute coronary syndrome also, and this patient did not have any infection. So we can stop antibiotics at that point. So these kind of calls we need to take once we have little more information available. We can, whenever in doubt, we can start off with antibiotics, but we need to review them at every 48 hours or maybe daily, whether the antibiotic is needed, whether we can step down to a narrower spectrum, whether we need to escalate the antibiotic, or what is the information from the culture reports based on which we can either give a targeted therapy. So these things we need to do on regular basis whenever we have started a patient on antibiotic. Now, the other 2-3 aspects of prescribing antibiotic is that we should also try and focus on preventing the transmission of infection of from one patient to another. This is very, very important because a patient can transmit an infection from one patient to other, and that needs to be prevented. And we should follow standard infection control practices, and also perform hand hygiene, which is the most important step in preventing transmission of infection from one patient to another patient. Also, we should keep in mind that when we should use invasive devices like catheters, Foley's catheter, CVC, or endotracheal tube for as long as duration it is needed, and we should follow all the insertion bundle and also the care bundles whenever a patient has these invasive devices. So these are some of the basic principles of antibiotic usage that focuses on diagnosis, on optimal treatment of infection, and then reassessing the antimicrobials on almost on a daily basis, whether we can stop them, de-escalate them, switch to an oral therapy, or give a narrower spectrum that should be discussed, or that should be kept in mind daily on rounds, and then also focus on preventing transmission of infection and hand hygiene to prevent transmission of infection to other patients. Now, these are the goals of antimicrobial stewardship. They help in improving patient outcome. They reduce the collateral damage, like reduces the toxicity, reduces the rates of Clostridium difficile infection, reduces surgical site infection, shorter length of stay. All these things are the part of collateral damage, and which are actually reduced by following antimicrobial stewardship policy. And they obviously, because antibiotics are very costly, and if we follow antimicrobial stewardship, then it helps to reduce the cost and the economic burden on the patient also. Now, AMSP actually is not a one person's job. We need to have a team. We need to create a team in our hospital. This team will have members from different specialties, like a physician, an intensivist, microbiologist, infection control nurses, head of departments or clinical leads of various units, then data entry operator, IT staff, nurses. All these things, all these personnel actually form a AMSP team, and they all have different kind of roles. And in our hospital, in our practice, we need to identify areas where we need to focus on AMSP. If we suddenly decide to start or follow AMSP program or AMSP protocol in our hospital, that may not be feasible. We may decide to start from an area like an ICU, or an area where there are high consumption of antibiotics, or maybe just an outpatient clinic where we should be considerate about using the antibiotics judiciously. So we can start from one area and then later on expand to other parts. Then there are two strategies. One is the pre-authorization, and the second is the prospective audit. I would just discuss them with two cases. So this is a case, again, a common case which we routinely see, uh, that you receive a call from ICU for a patient who needs to be started on ceftazidime avibactam. So now we decided to go back into the details of this case. This actually is a 60-year-old male admitted in ICU after suffering a massive myocardial infarction and has got a cardiac failure and has been on ventilator for the last 12 days. Now he develops a new onset fever on day 11 on ventilator, worsening respiratory parameters, leukocytosis with patches on the right lower zone in the chest X-ray, hypotension and requiring inotropes. The ET aspirate endotracheal tube aspirate was sent, and this showed on Gramstein GNB. And the primary team wants to start this patient on ceftazidime avibactam, which is a newer BLBI combination. So now the AMSP team has been called in to see the patient and decide whether the ceftazidime avibactam is justified for this patient or not. So we reviewed what are the common causes of nosocomial pneumonia or VAP in South Asian countries. And the most common cause is actually Acinetobacter, followed by Pseudomonas and Klebsiella. So since Acinetobacter and Pseudomonas are the common causes of VAP, so we know that this newer BLBI combination does not cover these two pathogens very well. So it is not a good choice. So we decided not to start. So because we could have empirically just said that you can start this patient on ceftazidime avibactam, but actually by reviewing all this information, patient has a VAP, and the most common cause of VAP is an Acinetobacter not being covered by this newer BLBI combination. So we decided not to start ceftazidime avibactam. So that is a good AMS practice which we need to follow. So then another case, 24-year-old male presented with acute appendicitis, no perforation, clinically hemodynamically stable, undergoes a laparoscopic appendectomy and was empirically started on meropenem with metronidazole. This is the one of the most common scenario, most common thing which we can use in antimicrobial stewardship is the dual combination. We can act on this double coverage here. So his pus culture showed a pan-sensitive E. coli, which was sensitive even to meropenem. Now, what are the potential AMS interventions here? So before we go to the AMS, let's look at the local antibiotic guidelines. The local antibiotic guidelines suggest that you can give a cefoperazone sulbactam or even an ertapenem or a carbapenem. Cefoperazone sulbactam would have been a preferred agent here because it has got a narrower spectrum than meropenem and the patient was hemodynamically stable, so we can use that. So because this patient was prescribed a combination therapy, one point which I wanted to highlight here is that meropenem has got a very good anaerobic coverage, and whenever you are using meropenem, you do not need to give metronidazole for additional anaerobic coverage. So this combination, in this combination, metronidazole is redundant, and we need not use metronidazole whenever we are using either meropenem or piperacillin tazobactam in our patient. This is very important for our surgical colleagues because they deal a lot with intra-abdominal infections, and they believe that anaerobes are actually a very important pathogen in intra-abdominal infections. So if we are using meropenem, we need not give additional metronidazole to provide anaerobic coverage. Now, another very important aspect which we need to keep in mind whenever we are managing infectious syndrome is the duration of therapy. We always have a tendency to give antibiotics for a longer duration because we believe that the longer duration, the treatment would be better, but that actually is not true. Longer duration of antibiotics, we already know, has been associated with increased risk of development of resistance or increased toxicities and increased cost to the patient. So, for example, pneumonia, community-acquired pneumonia, the recommended duration is only 5 days. For HAP and VAP or a nosocomial pneumonia is 7 to 10 days. For cystitis, only 3 days. Complicated UTI, 7 days. So we need to restrict the duration to what has been defined in the guidelines. So in this case, the AMS response was that empirical choice was wrong in this case. Meropenem alone would have been sufficient, or even a cefoperazone sulbactam. And double coverage was actually not needed, and the prolonged duration because the surgery has went smooth, and was also prolonged duration of antibiotic was also not needed. So coming to my last slide, AMR is one of the top global public health threat. AMR is associated with significant morbidity and mortality. Misuse and overuse of antimicrobials in human, animals, and plants are the main drivers of AMR. AMR affects countries in all regions and at all income level. And South Asia, this is even bigger problem than the global burden. Efforts directed at reducing AMR are needed at all levels. And AMSP is the most important cog in preventing that AMR. Thank you, and I'm open to take questions.
Thank you, Dr. Deswal. Really a wonderful lecture. And here I would like to highlight some important points of AMS. First, we have to decide whether the disease is infective or non-infective. If it is infective, whether it is bacterial, viral, or fungal. If it is viral, then don't prescribe antibiotics because antibiotics are not effective in most of the viral illnesses. Like most of the sore throats are usually viral. For those, we have certain scoring systems, and if we do those scoring systems, then we can decide, or if we take syndromic approach of any disease, then we can decide whether it is the disease which requires antibiotic or which don't require antibiotics. For empirical therapy of antibiotics should be reserved only for very serious life-threatening infections. Otherwise, don't use antibiotics empirically. And if we are using an antibiotic empirically, before using antibiotics, as Dr. Vikas has told, always take the blood cultures or urine cultures or pus cultures, whatever is the source of infection we are suspecting. And then whenever we get the cultures which are positive, then we narrow down the spectrum of the antibiotic, and definitely we should stick to that to reduce the infections. And definitely duration of treatment, as Dr. Vikas has told, it is really important. It should not be very less, and it should not be very high also. So duration should be as appropriate as indicated for that particular infection. And definitely it needs a teamwork for antimicrobial stewardship. We have to train our team, and we have to follow basically WHO guidelines of AWARE, where they have divided antibiotics into three classes: excess, watch, and reserve. Excess antibiotics are those antibiotics which are basically free, or you can use them rather more frequently for the accessible infections. Then watch antibiotics are those which are to be used sparingly and very, very carefully. And these reserve antibiotics are only to be used by the senior infective specialist, Dr. Vikas Deswal, whenever they are required. Otherwise, they should not be used, and they should be reserved before recommendation from the infectious disease specialist only, or before getting the culture reports positive for those antibiotics. So these are my inputs for this topic. And if any of the delegate requests any question to be answered by Dr. Vikas, then they can unmute themselves and ask directly, or they can put their question in the chat box.
Good evening, sir. So I have put my question in the chat box.
Yes,
So,
ma'am.
antibiotic policy would you recommend for our hospital antibiotic policy, which I should take as a reference?
Ma'am, ICMR has come up with very nice guidelines. You can download them and you can use them, ma'am. They're very thorough and very lucid guidelines, very nicely written, ma'am.
Thank you, sir.
They have been that is a combined effort by intensivist, microbiologists, ID physician, and many general physicians also.
So another question, sir. The tests, we are not actually doing tests like to identify NDN, green, OXA48, etc. because of the cost factor.
Yes,
How
ma'am.
important is this?
Ma'am, this actually that is very important. The rapid diagnosis actually is very important, and this is one very important aspect of tackling AMR and initiating appropriate therapy at the earliest. So whenever we have a sick patient, we should use sick patient, hemodynamically unstable patient. We should use rapid diagnostics, molecular diagnostics, which would help us in identifying the pathogen and the resistance genes at the earliest. And then based on them, we can tailor our therapy. So we at Medanta, we have Carba-R, we have BCID2 panel, we have multiplex PCR panel, and we have sequencing panels also, which we use depending on scenario to scenario.
Okay, sir. So,
Any
any
other?
idea about the cost factor of these tests?
Now, most of the multiplex PCR are these BioFire multiplex PCR. They cost somewhere between 12 to 16,000, like respiratory multiplex PCR, which is both upper respiratory and lower respiratory, both are available. Then you have stool PCR. Then you have meningitis PCR. They cost somewhere around between 12 to 16,000. Then you have a BCID2 panel, which is on a positive blood culture. So
Yes, sir.
that also costs somewhere around 12 to 16,000. But what they do is that BCID2 panel or these kind of tests, they would tell you the pathogen and the resistance genes around 48 hours earlier than your conventional cultures. But the limitation is that they would only tell the pathogens which are present on their panel. They would not tell us about the pathogens which are not present on that panel.
Okay, sir. Thank you, sir.
Good evening, Dr. Vikas, for making this beautiful presentation. I would like to know, you have although referred to the ICMR report, so we'll follow through that. But my question is, does ICMR report take into account the self-use of antibiotic by the patients in some way?
So this is actually, this ICMR report is on AMR, antimicrobial resistance.
Right.
So what they have done is that they have taken the pathogen of interest like Salmonella, Streptococcus pneumonia, Staph aureus, from these community pathogens, and then both community and nosocomial pathogens like E. coli, Klebsiella, Acinetobacter, Pseudomonas, and they have tried to see, and they've tried to collate the data from 60, 70 odd center. I don't remember the exact number of hospitals, but each category has like some 5, 6,000 isolates, 12,000 isolates, 10,000 isolates. So a significant number, and these hospitals are from different part of the country. So very much representative of what actually is happening in different parts of India. So what they have tried to collate is that which antibiotic is susceptible for in what percentage against which bacteria. So that information they have tried to gather from this ICMR report, and this report has been is being generated since 2017, and this report is released every year. You can just go to the ICMR website and you can see reports from 2017 onwards being released every year.
Okay.
And if you look at these reports, the one thing which is very common, they're very nicely plotted in different graphs also, that every year the resistance is actually increasing.
Increasing. Right.
Which is very, very concerning. As I said, the penicillin resistance in Streptococcus pneumonia was less than 5% in 2005, 10% in 2009, and now it is 80%, 75 to 80%.
Right. And you have mentioned like several meta-analysis and reviews on the use of AMR in different parts of the world and in India.
Yes, sir.
Like, is there any review that focuses upon which is the most widely prescribed antibiotic, which is not there is an actual use of it, but most widely prescribed, any sort of like rankings?
The abused by patient themselves is azithromycin, no doubt in that.
Okay.
Abused by physicians, our doctor community, this is, oral cephalosporins, cefixime, cefuroxime. These are the most commonly abused. Then there are few class of drugs which are like just only which are not backed by any science or which are not backed by any evidence. Like there's a drug called ferropenem, which the company claims that this is an oral carbapenem, but there is nothing like oral carbapenem. That actually is not a carbapenem. That drug is actually doing more harm than benefit, and that actually has a very significant role in propagating carbapenem resistance. So we should not be using these kind of drugs.
Thank you. Response.
So what is your switch down oral therapy for hospital-acquired infections once the patient is better with carbapenems or polymyxins, like you have given for 7 days. Now you're
Yes, ma'am.
discharging the patient. So what is your oral choice?
So, ma'am, if the patient has come from that depends on the syndrome and the clinical condition of the patient. If the patient has come from community, has got a pneumonia, I would just give 7 days of therapy and stop it. Ma'am, I would not give anything beyond that. If some patient needs an oral antibiotic or needs a longer duration of therapy for conditions like osteomyelitis, infective endocarditis, liver abscess, then in that situation, obviously, would depend on the culture and sensitivity report, ma'am.
Like so most commonly we like suppose we encounter Acinetobacter and Pseudomonas, like they are okay after 7 to 10 days therapy. Now we are discharging them.
Ma'am, I'm assuming that Acinetobacter and Pseudomonas are the two leading cause of happen-ware. So if you've given a 10 days of therapy, that is good enough. You do not need to give any oral therapy for the treatment.
And so what are your comments on the oral use of phosphomycin? Some are using as a stat dose, some are doing as a desperate situation every alternate day.
Now, first thing we need to be very clear about one thing is that oral phosphomycin has only two indications. One is cystitis, uncomplicated cystitis, and second is chronic prostatitis. Beyond these two indications, there is no role of oral phosphomycin. And for cystitis, a single dose of oral phosphomycin is good enough. For a chronic prostatitis, you need to give it for 6 weeks, one dose every third day.
Okay, thank you, sir. So how frequently you use IV phosphomycin?
Ma'am, I work in a quaternary care referral center, so we get to see a lot of MDR bugs, ma'am. And so now, since phosphomycin has a role in complicated UTI, so I use it for my sicker patients with complicated UTI due to carbapenem resistant Klebsiella or carbapenem resistant E. coli. That is where I use, ma'am. But now we have other options, better options than phosphomycin for complicated UTI, like your newer BLBI combination like ceftazidime avibactam for Klebsiella and plazomycin for carbapenem resistant E. coli.
Okay, sir. Since phosphomycin you are using as a monotherapy or
For a
combination?
for a UTI for a complicated UTI patient is stable, then as a monotherapy also we can use that.
Thank you,
But
sir.
hemodynamically unstable bacteremic patient in ICU, definitely a combination therapy with cholesterol.
Okay, sir. Thank you, sir, for answering so many queries.
Thank you.
Thank you, Dr. Deswal, for an enlightening talk on
Thank you, sir.
microbial resistance. Thank you, participants. Thank you, Dr. Pavan Goyal, for keeping the flag high. Hope to see you next week. Thank you.
Thank you. Thank you, everyone. Good night. Good night, Dr. Deswal. Good night,
Good night,
everybody.
sir. Good night. Thank you, sir.
Dr. Ma'am, Sunila Soni, ma'am.
Thank you, sir. Good night. Thank you.
Good night.